Fix the shaft of femur first and then the neck of femur.
Fix the shaft of femur. How?
By nailing or plating. Then we can go for neck of femur fracture fixation.
Okay.
Because if the shaft, if we fix, we can give traction.
Yeah. That's a good point. That's a very valid point.
After fixing the shaft, we
for
can
neck
put
of
the
femur
patient
fracture.
in traction and we can reduce the neck, and it will be easy for fixing the neck of femur.
Agreed. Definitely agreed. So you would require traction on fracture table in most cases of fracture neck of femur, and hence you would rather have a fixed shaft so that you could align the fracture at the neck. Good point. Any other points? Anyone else wants to put in? So basically, it's all boils down to these things only. Whether you use a single implant or two implant, which one, and if you have decided two implant or one implant rather, which one would you do first? How would you do it? Okay. So nothing is right or wrong. I mean, both could be very well employed. The last argument that was put forth that you could do a retrograde nail, have the shaft fixed, and then do the neck also is a very valid point. But having said that, you would require to slightly plan. Now, that's what we are going to talk about. So what are the different, not rather different, but how we could do it. Now, I'll just show 3 case scenarios. So this entire argument of 1 versus 2 implant came because of certain publications which told that the chances of failure in these subset of fractures are very high because these are very high velocity injuries, and hence it can fail. So the moment you have a failure of one fracture, you would rather have 2 different implants fixing both the fractures, because then whichever fails, you can tackle only that without disturbing the stability of the other implant. Okay. Now this types of reports made surgeons think of using 2 implants, but now enough literature has come that even 1 implant is good enough, and if it fails, you could tackle it, and I will cover even that. Now, this was a 59-year-old gentleman. We could see here fracture neck and a subtrochanteric fracture, but you could see this entire wedge all the way till here. So this has gone all the way till the lesser troch. So if you could see here, there's a fracture line going all the way here. Now, in these scenarios, the second argument of trying to put a retrograde nail is out of question, because even if you put a retrograde nail, where will you put your screws? Because the fracture line is going all the way till the lesser troch, right? So whenever you do a retrograde nail, you have to leave enough space for the trajectory of DHS or cannulated cancer screws into the neck. So this entire area below the lesser troch, the particular nail that you're going to use should not encroach into that particular area. Now here, if you do that, it is not going to provide stability to the subtrochanteric fracture. So that is definitely ruled out. So now you are left with only one option. This is going to be an antegrade nail. Some of you may argue, what about a long DHS? I'm not saying could not be done, but it doesn't provide enough stability for the subtrochanteric fracture. We know that surface implants do not provide enough stability for the subtrochanteric fracture. Okay. So cephalomedullary nail, but whenever we do that, there are certain things that we need to, we have to do it, because like I told, chances of failures are high. So we need to reduce the chances of failures. Now this is, so the protocol that is routinely followed, one of the protocols I may say, is put it on fracture table and have a look what happens. So do not think beforehand that whatever traction we give is not going to act on the neck. Everything is going to get dissipated at the shaft, and we will not be able to manipulate the neck, all those things, right? So check it out now. Put it on the fracture table, give the traction, and check what happens. Now you can see this is reduced, but we have a external rotation of the proximal shaft fragment, as we could see the lesser troch. And here we don't have a perfect anatomical reduction of the neck. Again, like I told, for any neck of femur fractures, anatomical reduction is what is desired. We cannot have anything less than that, because then it may end up in failure. So what you could do is use simple percutaneous methods. You could use a shank spin. Okay, so internally rotate that. So see to it that you are going to put it very anterior or very posterior. Here, since anteriorly there is one more fracture, that wedge which is going, we use this very posteriorly. The entry point will be somewhere there for the nail. So put it very posterior and then internally rotate. So once we internally rotate, also we could see there is a match in the lateral view of the neck now. So this nice S curve that we describe on the lateral view is back now. And then once we achieve the reduction, you can hold the reduction with a couple of pins. Now these can be 3.2 pins that are available in the set of cephalomodular nails, or we could use even long K wires. Okay. Now all these need to be planned preoperatively and be there in the instrumentation set, because what happens is many of the cephalomedular nailing set gives you those flimsy guide pins which are not good enough. Now, getting reduction is one entity, but maintaining this throughout the procedure is a bigger task. Why? Because imagine we have not held it on. So we are going to take our entry somewhere there, entry, guide wire, reamer, hammering the nail, everything, right? It can displace. And once it displaces interop with the nail inside, it's going to be extremely difficult for us to re-achieve the reduction. So that's why once you're happy with the reduction, hold the reduction with 1 or 2 pins. Okay. So again, plan the trajectory of the pin in such a way that it's not going to come in the way of your nailing. So this is one pin being one pin being used to hold the reduction. This is the second pin being used. Okay, now we have a good profile for us to proceed with the nailing, and all this is done percutaneously. We do not need to really open it out. Having said that, if it does require open reduction, there should not be any harm in opening it. Okay, so most of these we could achieve percutaneously. So once we are done with that, then proceed with guide wire. Again, critical in these proximal femoral shaft fractures is to get the entry in the piriform fossa. Right, not the tip of trochanter, but piriform fossa, because if we go anywhere laterally, the chances are very high that we're going to end with the varus malreduction by the time the nail and the screws are passed. So to overcome that, take a medial entry point into the piriform fossa with the guide pin. Now again, trick here would be not to use the awl, because when you're using the awl, we are going to use a lot of blunt forces to mallet the awl in, and that itself can cause some displacement. So you could use the guide pin on the drill and insert it. Okay, so pass the drill, use the entry reamer, and then we see a huge wedge of bone, and guide wire obviously tries to keep going out from there. So what you can do is you can use the bent guide wire. So we can create this slight bend and redirect the guide wire. Okay, so redirecting it posteriorly here, redirecting, so it was going out medially, so redirect it laterally there, and see to it the guide wire passes. After that, use a ream, and again the recommendation here would be to ream +2, in the sense if you're going to use a 10 size nail, ream it on to 12. We don't want hinder passage of the nail, because if there is hindrance, we're going to mallet it in, and that itself can cause displacement of the neck, right? So again, use the sleeve when you're reaming, otherwise the chances are that you're going to lateralize your entry. This is especially true in a trochanter with shaft, not that much of issue with neck with shaft, but keep the steps similar so that you do not skip any steps. Okay, ream it, pass in the nail, and then everything is the regular instrumentation of what. So here, as we can see, this is Mesa nail screw, which is put with the jig. Now this particular system allows a Mesa nail screw through the jig, and there are 2 other screws which are through the nail, right? So this is, and distally you're locking 2, and as we can see, it goes on to heal well. Now, this is the ideal scenario that we can think of, where you use a single implant, you reduce the neck well, you reduce the shaft well, everything is fallen back into place, you were able to pass in the nail, and everything healed. Now, the question comes, what happens? The biggest challenger to this particular scenario is what if we had done this and say there was a non-union in the subtrochanteric area, or what if we had done this and there is a non-union in the neck? So you use a single implant, what to do? So those scenarios also we'll just discuss. So this is one such patient, 42-year-old gentleman. He had a open type 3 fracture shaft femur and presented pretty early. This is what